So I would just like to welcome everybody. It's a great honor for me to introduce Dr. McIntyre. He's been a psychiatrist here in the South Okanagan since, I think, the mid-90s. And when Matt came here, I was a team leader for the ASTAT team, and we didn't quite know what to do with this guy. He had such a medical view of everything, and so he really challenged us to look at the DSM, to look at how we did mental status assessments, how we did assessments, and I have so greatly valued that learning over the years and always think back to some of those conversations. So it's with a great honor that I introduce Dr. McIntyre.
Thank you, Alan, and thank you for asking me to talk to you about bipolar disorders and depressive disorders. Got a little bit of an accent, so if you don't understand what I'm saying, please just ask and I'll try and clear things up. With the DSM-5, I think there's been some advantages and there's been some disadvantages. As you are aware that the DSM-5 is now harmonized with the ICD-11, and they've made a few general changes, especially in terms of mood disorder and bipolar disorder. I think this has been actually quite beneficial because it has grouped certain types of depressive disorders together, and I think makes it much easier. As a general rule, they've removed the category not otherwise specified, and they've divided into two groups: the other specified disorder, where the clinician can go and specify that the depression or the mania is due to a specific reason, whether it's medical or drug use, or it can be unspecified when you choose not to specify and you're not exactly sure. The other thing that they've gone is that there's no more than 5 axes. And, I have to be honest, I do miss axis 5, because I think axis 5 used to indicate to us prognosis, but also think that was the axis that we used most inappropriately. Being in this community for a long time, I often go back and look at what I rated patients' GAF on from one year to the other, and it's quite scary, the big variation in my ratings. So what we're doing now, we're using a thing called the WODAS, and I'm just going to go a little bit about the WODAS. This is the World Health Organization Disability Assessment Scale. The patient completes this. Takes them about 10 minutes to complete. We can use it in all clinical and general population groups, and it was tested worldwide in the DSM-5 field trials. Thanks, Alan. Next slide. What the WODAS is, really look at 6 important areas, and patients rate this from 1 to 5, and the big areas that we look at is understanding and communicating, how you get around, and there's my first big spelling mistake, self-care, getting along with people, life activities, and participation in society. Next slide, please. The way we rate the WODAS, and there's several ways that you do it. The way I rate the WODAS is I take each of those 6 categories, add it up, divide it by the number of items, and get an average score. And then I calculate add the 6 average scores together, and this gives us a general idea of what the patient's overall disability is. Does that make sense to everyone? So pretty simple. So no more axis 5. We rate the WODAS from 1 is no difficulty, 5 extreme difficulty, cannot do, and it's all how the patient has functioned within the past 30 days. Okay, next slide. So let's talk about bipolar and related disorders. The lifetime prevalence of bipolar, North America around about 0.6, bipolar 2 disorder 0.3, 0.8. What we sometimes forget is that the lifetime risk of suicide with bipolar patients is quite high, up to 15% higher than the general population. What makes bipolar such a difficult disorder to diagnose is that bipolar is predominantly a depressive disorder. So every patient that you see that you screen for depression, needs to be screened for bipolar. Doesn't matter how profoundly depressed this patient is. Bipolar 2 most probably have a higher genetic risk, and we quite often use terms loosely in bipolar, and I think this is what I like about the DSM-5, because it's giving us subcategories that is much more descriptive. So the term rapid cycling really means 4 episodes per calendar year, whether it's mania, hypomania, or depression. A total of 4 will indicate rapid cycling. So we've moved from a categorical approach to a dimensional approach. In the DSM-4, can everyone see the slide well? Is it okay? So we've moved from, in the DSM-4, manic, mixed, and depressed. We're now much more on a spectrum where we talk about manic with mixed features. Those are the group of patients, while they're manic, they start exhibiting depressive symptoms. And we have the same with patients that are depressed, that now presents with manic or hypomanic symptoms. And then on the other spectrum, the depressive group. I'm not going to go through the individual criteria of mania and hypomania because I think we can all do it. Because I can't even see my own writing there. So in bipolar 1, we've dropped the mixed disorder, and we now talk about mixed phase. That's the specifier. And in terms of mania and criteria A, we added a persistent increased goal-directed activity and energy. We always knew that that's part of mania. It's just part of criteria A. For bipolar 2, you need a lifetime experience of at least a major depressive disorder and 1 hypomanic episode. As a clinician, I sometimes struggle with what is hypomania and what is mania. And I think DSM-5 has been good in the sense that we now have specific criteria to identify this is what hypomania looks like. One of the mistakes that we used to make is that we think that bipolar 2 is the milder version of bipolar 1. It is the milder version in terms of mania, but if you look at the impairment, patients with bipolar 2 spend a long time in their depressive disorders, and they're really very difficult to treat. We don't have bipolar 3 anymore. It's now substance or medication-induced bipolar and related disorders. And if you get a patient that becomes hypomanic after being on an antidepressant, you now go and you diagnose these patients as bipolar disorders. All right, so let's talk about hypomania. How do we distinguish between hypomania and mania? So a few simple things. The patient gets admitted to hospital. The diagnosis is mania. The patient has psychotic features. The diagnosis is mania. Irrespective whether you put down hypomania, once the patient is admitted, this is considered to be mania. So you have a distinct period of abnormally persistent, elevated, expanded mood lasting for at least 4 consecutive days. If the mood is predominantly irritable, we need 4 symptoms. And the key is here that it's an unequivocal change in functioning that's uncharacteristic for this individual when they're well. And this change got to be observable by other people. And I think that's really important. In order to make the diagnosis, we get a lot of patients coming to the office stating, I have bipolar mood disorder. Gone on the internet and I've rated myself. I have periods of mood swings. Like it's wrong to be happy, right? My mood can go from depressed to happy. And the key is really to call someone that knows this patient to identify this observable change. And I'm quite impressed that the DSM-5 got this, because I think this simplifies the diagnosis for us. The other key is, this episode is not severe enough to cause marked impairment in social occupational functioning. Some people with hypomania can actually function quite well. They may actually function better than what they function when they're not ill at times. So this doesn't cause marked impairment. As I stated, once the patient gets admitted to hospital, or if there's psychosis, the diagnosis is mania. Next slide, please. So let's talk a little bit about these specifiers. And, when you look at it initially, it's quite a bit there. So we talk about, you have to specify if this most recent episode was mania, depression, hypomania, or unspecified. You have to specify whether this is mild, moderate, severe, in partial remission and full remission. So the diagnosis becomes a mouthful by now. And then we also have 10 different specifiers. And it's taken me quite a bit to learn these different specifiers. But, we can group some of them together. Mood congruent, mood incongruent, that's about the same what it was. Catatonia, atypical features, rapid cycling, melancholic, and the big one that we all use most often nowadays is anxious distress. And then we have peripartum and a seasonal pattern. So during the course of the talk, I will address a few of these different criteria, just point out the important changes. So for bipolar 2, as we said, a hypomanic and at least one major depressive episode. Next slide, please. Now, let's talk about those with the mixed features. So we're looking here at patients with a bipolar disorder, currently a major depressive episode, with mixed features. So in this group of patients, you've got to have at least 3 manic or hypomanic symptoms. And those are the criteria for mania. Now this becomes difficult to distinguish this group of people from agitated depression. When is this an agitated depression? When is this a bipolar, major depressive disorder, mixed state? So once you have this elevated expansive mood, inflated self-esteem, flight of ideas, the diagnosis is a mixed episode as your specifier. Next slide. We have the same if the patient is hypomanic or manic and they present with depressive features. Once again, you need at least 3 of those symptoms. And there's got to be present the majority of the days of this episode. So not just 1 or 2 days, the majority of the days. Okay, next slide. So what makes bipolar so difficult? Well, number one, you see the patient for a very short period and you've got to make a longitudinal diagnosis. And there's several screening tools that we can use. One of the screening tools that we sometimes use is the MDQ. If we use these rating scales, the patients with bipolar often see 3-4 clinicians before the accurate diagnosis is made, or they can be ill for about up to 10 years. The other problem is that bipolar has high risk of comorbidity. As we said, predominantly bipolar is a depressive disorder. So these patients might often get diagnosed as major depressive disorder. Anxiety is quite prevalent, substance abuse, ADD, and then we get these patients with borderline personality disorder or cluster C. And in the old DSM-4, we used to talk about patients on the affective dysregulation spectrum. Now, what does that mean? It depends how the clinicians are going to interpret it. Next slide, please. What DSM-5 did, came and gave us what we call the atypical specifier. And here the patient can present either with mania or with depression, most often depression, and these patients have prominent mood reactivity, where these patients' mood all of a sudden become better because something good is going to happen or something good happened. They have two or more of the following: significant weight gain or increased appetite. They sleep too much, and then this latent paralysis, this extreme fatigue that they have. And in red there, for those that can see, it's a long-standing pattern of interpersonal rejection sensitivity. Now think about patients in the DSM-4. When we saw a group of patients like this, what did we think about most often? Patients with depression that all of a sudden becomes brighter because something good happens. They're really sensitive to rejection. First thing that came up was a personality disorder. I think DSM has clarified this for us, that this is the atypical specifier. Be aware, this is most probably bipolar rather than a pure personality disorder. A few other things to help us with the diagnosis. Earlier the onset depression, the more likely the diagnosis is bipolar rather than unipolar depression. Next slide. There are a few things that can help us. These patients with the atypical depressions, the hypersomnia, the increased appetite, psychomotor retardation, lability of mood, multiple prior episodes of depression, diagnosis most likely bipolar rather than unipolar. Don't be afraid to give these patients mood charts to complete. You don't have to make the right diagnosis at the first interview. Take your time, make sure that this is bipolar, not unipolar. Okay, next slide. So other things that we can look at is the substance or medication-induced bipolar disorders. This is when the patient presents with predominant mood disturbance, whether depressed, irritable, or expansive, and it's closely associated with that it developed during or soon after substance intoxication or withdrawal or exposure to the medication. The substance got to be able to produce those symptoms. And it's not better explained by a bipolar or related disorder. I just saw someone in emergency with crystal meth, now depressed. So is this a crystal meth-induced bipolar disorder? Is this crystal meth-induced depressive disorder? Or is this part of the intoxication? So we're going to wait a few days to decide before we make the right diagnosis. This doesn't happen during the course of delirium, and it causes significant distress or impairment, and do specify the substance. And you can add to this the substance use disorder if this mood disturbance is due to the substance. Next slide. So, cyclothymic disorder, once again back in the DSM-5. How often do you guys diagnose a cyclothymic disorder? I know I don't diagnose it often. Perhaps I don't know the criteria well enough, or perhaps as part of a personality, but duration of at least 2 years, we had numerous periods of hypomanic or depressive symptoms that does not meet the full criteria for major depressive disorder or hypomania. These have been present for at least half of the time, and they've never been without symptoms due for longer than 2 months. We have other specified bipolar and related disorders. These patients that present with short duration hypomanic episodes, 2 to 3 days in an MDE. Perhaps we called them in the old days ultra rapid cycling patients. Those with hypomanic symptoms with insufficient symptoms to meet the criteria plus an MDD, or short duration cyclothymia for less than 24 months. Or you can go and not specify what types of bipolar it is. Next slide. So to summarize, we've got all these different specifiers that I think is going to help us to have more descriptive terminology to describe the patient's disorders. In terms of depressive disorders, there's been a few changes, and I think the most important change for me is the anxious distress specifier, because we know that anxiety is such a huge factor in patients with major depressive disorder. They've also dropped the bereavement exclusion criteria, and we have 1 or 2 new diagnoses amongst the depressive group. Next slide, please, Ellen. So, how do we distinguish major depressive disorder from a normal bereavement reaction or a normal grief process? Okay, so you have people with a grief reaction. They go through the different stages. They can still have a bit of humor. They can still function well. But as soon as they develop anhedonia, feelings of worthlessness, suicidal ideation, and a significant impairment in their social and occupational functioning, the diagnosis now moves to major depressive disorder. DSM-5 also have a category called a complex bereavement reaction, which is not part of my talk, but I would recommend everyone to go and read a complex bereavement reaction, how to deal with that. So they've moved the 2 months exclusion for grief, because grief takes much longer than 2 months. And the key is, be aware for the anhedonia, the worthlessness, and suicidal ideation. Next slide, please. So, a new diagnosis, disruptive mood dysregulation disorder. Anyone made this diagnosis before? I'm grateful I don't see kids. But if we look at the criteria, these are severe recurrent temper outbursts manifested by verbally and behaviorally that are grossly out of proportion in intensity or duration or provocation. This diagnosis is made in young people over the age of 6 and the age of 18, and the onset is usually before age 10. These angry outbursts is more than 3 times a week, and the general irritable mood most of the time for at least 12 months. There's no 3-month period where they're not irritable. So what would your differential diagnosis be in this group of young people? What would we consider?
Attention disorder.
Okay, attention deficit disorder can be a possibility. How about oppositional defiant disorder? Now, in my days, we used to have a term, adolescent turmoil, whatever that means. Perhaps this is a group of patients that fall within this group. Perhaps this is the group of patients that we should keep an eye on, that this actually may be the beginning of a bipolar disorder. So in children, adolescents, I think this is an alternative to bipolar disorder unspecified. The term dysthymic disorder no longer exists. We now call it a persistent depressive disorder. And the key with a persistent depressive disorder, that is still the same thing. The duration is at least 2 years. You're never symptom-free for more than 2 months at a time. And while you're depressed, you need 2 or more of those 6 criteria, the main vegetative symptoms. We quite often made a diagnosis, the so-called double depression, which meant patients with a dysthymic disorder and a superimposed major depressive disorder. So this group of patients will now be classified as a persistent depressive disorder, which means while the patient has this old-term dysthymic disorder, they can have a comorbid major depressive disorder, and that may be continuous for 2 years or longer. So in order to capture those patients, we need to specify, is this the pure dysthymic syndrome that we're seeing, or is this the dysthymic syndrome with the pure MDD, or do we have an intermittent MDD on top of this dysthymic disorder? It gets a little bit complicated, but I think once we work this out, it will be easy to sort it out. You also have to specify if the onset is before age 21 or after age 21. And once again, you have to specify the severity. So one of the questions that comes up in the DSM-5 with all these specifiers, how does it really help us? And I think this really adds to the prognostic indications of these disorders. If you have the onset before age 21 versus after age 21, I think it makes a difference. There's a recurrent MDD or a persistent MDD. I think these people are more treatment resistant than in the other group. And I think it simplified us because we misused Axis 5 so much in the DSM-5. We now have these specific criteria to identify the severity of these disorders. Next slide. So one of the difficult depressive disorders that seems to be in and out of the DSM-5 is the premenstrual dysphoric disorder. Then it's an item under investigation. It's back in the DSM-5. Excuse me. And we have specific criteria. You need at least 5 symptoms in the majority of the menstrual cycle. And these symptoms got to be present in the final week before the menses, improves after the cessation of the menses, and diminish to absent in the week after the menses. Right? So specific criteria. We need at least one of marked affective lability, angry, outburst, etc. Marked irritability, marked depression, hopelessness or self-depreciating thoughts, marked anxiety, feeling keyed up or on edge. Very typical symptoms that we see in patients with true premenstrual dysphoric disorder. You also can have some of the following symptoms: concentration problems, marked changes in the appetite, sleep disturbances, feeling overwhelmed or out of control, and then the specific physical symptoms: tenderness, swelling of the breast, muscle pain, bloating, and weight gain. So in total, you need 7 symptoms in the majority of the menstrual cycle. The key is here, the symptoms must have occurred in most of the menstrual cycles in the past year. But you actually got to go and measure it in at least 2 prior episodes. So you just can't come in and say, I have all these symptoms. Let's go, give the patients tracking where we can actually track these symptoms and make sure they've been present in the last 2 episodes, or 2 menstrual cycles. So Once again, in depressive disorders like bipolar, full remission, partial remission, unspecified. How do we determine if a patient has been in full remission? When is the MDD recurrent, or when is it just one continuous depressed episode? The patient's got to be well for at least 2 months between episodes. Then it will be in full remission. The most common diagnosis I make in my practice at present is major depressive disorder with anxious distress. Because we know anxiety is prevalent in patients with MDD, occurs in about 70% of patients. This group of patients usually have worse prognosis. They're more difficult to treat. To make that diagnosis, you need at least 2 out of the 5 symptoms. Feeling keyed up or tense, unusually restless, difficulty concentrating because of worry, fear that something awful will happen, or fearful that you may lose control. So these symptoms sound very much like panic attacks or generalized anxiety disorder. But if they occur in the context of a major depressive disorder, you now have the opportunity to specify whether this is major depressive disorder with anxious distress. DSM-5 has also given us some severity indicators here. Mild 2 symptoms, moderate 3, severe 4 or 5 symptoms. Once again, I think to help us with the management of these patients, indicating the severity of disorders. So my most common diagnosis, major depressive disorder with anxious distress. We also now have a peripartum specifier. So I've gone from a postpartum depression. One of the items that I've always struggled is patients get referred and they get diagnosed as postpartum depression. So your postpartum period lasts how long? 6 months, 1 to 3 years, 1 to 1 year. I don't know. I think we all have different meanings what postpartum means. So they've turned this to peripartum because we know that about 40 to 50% of patients actually become depressed during the pregnancy. So they will be classified as peripartum depression. You still have to have the onset of the MDD within 4 weeks of delivery to have this peripartum specifier. If not, they will be classified as straightforward major depressive disorder. So a little bit of a change, right? The seasonal pattern. So we quite often see patients that come in and say, I have a seasonal affective disorder. And they go and buy these light therapies and it helps for a while, then it stops working. And DSM-5 came in and said there's got to be a regular temporary relationship between the onset of the MDE and a particular time of the year. Now, you can't diagnose MDD or a seasonal pattern if the patient knows they're going to be laid off in the winter, that there's not going to be enough work. So if there's an obvious seasonal related effect, the seasonal pattern doesn't apply to this group of patients. You also got to have full remissions for specific times of the year. And in the last 2 years, you've got to have at least 2 MDE episodes that have occurred and demonstrated temporal seasonal relationship. So I can't have a good year and then a bad year and a good year and a bad year in order to get a specific specifier. the number of substantially MDD episodes got to outnumber the non-seasonal MDDs. Make sense? Substance or medication-induced depressive disorders, very similar to the bipolar disorders. The symptoms develop during or soon after the substance intake or the withdrawal. Most important, the substance got to be capable of producing those symptoms. If the patient has a previous MDD or had mood disturbances prior, this is not due to the substance because we will rather classify it with the previous disorder. It does not occur exclusively during the course of delirium and causes significant distress and impairment. So be aware with this diagnosis that we don't identify patients that's an acute withdrawal of having a substance-induced mood disorder. All right, so we get other types of depressive disorders, and I realized this last night when I was reading through my talk. I just copied and pasted the slide, and it doesn't make much sense. So we're talking about depressive disorders due to another medical condition. Those are places like hypothyroidism, hyperthyroidism. We've got other specified depressive disorders. These patients with short duration, not hypomanic, but depressive symptoms. To make a diagnosis for MDD, how long do people need to be depressed?
2 years.
No, that's for a persistent depressive disorder, right? For a MDD, how long do these symptoms need to be present? 2 weeks. So if you have depressive symptoms 4 to 13 days, then they feel better. These would be the other specified depressive disorders. Those patients with recurrent brief depressions, I think we used to think these were personality disorder patients. And those where patients have depressive symptoms with insufficient symptoms. Next slide. On the other spectrum of this, we have the adjustment disorders, and that hasn't really changed. So what did the DSM-5 do to mood disorders? Actually been very little changes from the DSM-4. I think we've gotten more specifiers, more subcategories that will hopefully help us to get a more descriptive view of patients' mood disorders. Okay, any questions?
If I might ask, Dr. McIntyre, sometimes we see clients that are depressed and they're put on an antidepressant medication and then they get kind of slingshot into a manic episode. What's the thinking on that in terms of, is that a bipolar disorder or is it just being triggered by the medication?
Those patients will now be diagnosed as bipolar disorder because, especially if the mood symptoms persist after the half-life or duration of these patients, of the antidepressants. So these will be now diagnosed as bipolar patients.
Would a child or a teen ever be diagnosed with bipolar now, or would it more often than not always be this disruptive mood dysregulation?
No, I think, the DSM-5 doesn't come and specify the age of onset. Remember that slide that I showed earlier on where we said bipolar is actually, the onset is usually much younger than pure major depressive disorder. I think this disruptive mood disorder is just something, be aware that this is someone that you would like to follow longitudinally, that this may be bipolar. Patients with really early onset of major depressive disorders, diagnosis most probably going to be bipolar on the long run rather than unipolar. And there's been several studies in the Scandinavian countries really looking at the early onset if you look at the work of a Kiskel, earlier the onset, more likely bipolar than unipolar.
If I can ask another one, because I know another interest of yours is the medication side of things. Where do you see some of the medications going in terms of treatment for these disorders?
Well, I think CanMed has came out with specific guidelines for the treatment of bipolar disorder and major depressive disorder. I don't see a lot of new stuff on the market at present. I think in terms of depression, there's more focus nowadays on cognition. Really try and find medications that work on cognition. Don't know if I want to say too much about that here because I think that's outside the scope here and don't want to mention any drugs. But I think we have certain medications that may show or may have some beneficial effects in terms of cognition. In terms of depression, I think the key is really to treat patients until full remission. But I think, and I can only speak for myself, I quite often struggle with the so-called residual symptoms of depression and never know where you go, when is enough. But if we really think in terms of residual symptoms of depression, which are those last symptoms to improve? Concentration, memory, energy, motivation, and sleep. And how often do we ask about those cognitive symptoms? How often do we test for those cognitive symptoms? Yes, those are the symptoms that affect the patient's functioning most significantly. I think that's really an area that we need to look at.
A couple of questions here. Was it the shorter duration mood disorders that might replace the personality disorder?
Oh, I don't think it's a question that it will replace it. I think you have to be aware. And I'm thinking here more in terms of the shorter duration mood disorders, but also the unspecified. Remember, by the unspecified group, we talked about the interpersonal rejection, sensitivity, and mood changes in anticipation of something good or positive happening. So it doesn't replace it, just be aware that this is the category.
Okay, well, I just want to take a minute and thank Dr. McIntyre for joining us, and really appreciate you taking the time and joining us today. And but thanks very much.
Thanks a lot.